So as a general non-invasive cardiologist, thanks for being invited to your party. The other thing is that when I was explaining to my daughter, who was with me, that I didn't have my slides done last night, she was like, as a 10-year-old, she didn't quite understand. So I think 1 in the morning is kind of the MO for a lot of us, but at any rate. So first, I want to talk about what my definition of innovation is. As a general non-invasive cardiologist, there are no angiograms in my talk. I was advised by some of my friends last night that maybe I should do that to make sure everybody's engaged, but really it's a different perspective on innovation in healthcare delivery. So innovation to me is the application of new ideas in order to generate value. And what do I mean by value? Improving the outcomes relative to the costs or improving our revenue while maintaining optimal outcomes. Innovation is not invention, it's not necessarily the generation of absolutely new ideas, and it's not creativity or idea generation without application. We have to really apply it in routine care to make it innovative in our care delivery. And oftentimes, I think it's changing the perspective and how we think about things. So looking at something that we do every day, but changing how we do it in a way that's impactful and helpful for our patients. So what are the needs? First, we have needs of our patients. We don't meet the needs of our patients. I work at the Minneapolis Heart Institute, and we serve a large population across the 5-state region, but to provide a lot of our care requires for them to come to Minneapolis, which is a large drive for them, or transportation issues. How do we provide follow-up with them in a way that's convenient to the patient? In addition, oftentimes we don't think about what's important to the patient in terms of their outcomes, what's important to them for their quality of life and their health-related outcomes. So I'll talk about innovations that will help us there. Accountability used to be that we're really responsible for what happened within the silos of the hospital wall. Increasingly, we're going to be responsible for the population as a whole. So beyond their hospital stay, what happens as they return to routine care, in our case, the state of Minnesota and beyond. And then finally, gaps in variation. We know there's tremendous variation in terms of how we practice. There's also tremendous variation in gaps in achieving the optimal outcomes for our patients or providing the therapies that we know are best. So how do we address these needs with innovative solutions? And I'm going to offer 3. I could talk probably for 2 hours, but I'm going to offer 3 that I think that are on the cusp. So one is telehealth. So how do we use telehealth to improve outcomes for our patients, mobile technology, and then finally leveraging the data. So telehealth. First of all, what is it? Broadly, it's essentially the transfer of an exchange of information. When you've Skyped with somebody, that's telehealth, but not with a health-related component. So at the Minneapolis Heart Institute, we're using this type of technology to interface with the patient via a video conference. We have their medical information at the point of care so we can review their chart. We can have a conversation with the patient about what is the problem, what is the need. It meets the need of the patient. They're getting the care that they need out in their community that may be 3 or 4 hours away from where we are. This is oftentimes being used in the VA as well, where we have a large rural population that you need to provide those services. Within the frame of interventional cardiology, you could think about, well, what are those needs that we're providing the patient that potentially we could do better through a telehealth type of approach? I know within electrophysiology, they're using telehealth for wound checks. In the same way, we have patients that are returning to their primary care provider at 5 days for a check of their groin. Would it be better potentially to use a telehealth approach to have them see an NP within your practice to make sure that the groin is okay, that they're taking their medications, and they really get the follow-up that you need? So what are the impacts? Improved access and patient experience. It's real time, it's face-to-face, it's targeted testing and transfer, so that the patients that you're also seeing potentially in consultation prior to them coming to your center, that you know that you can help, as opposed to them coming to your center, you have a conversation, you say, well, actually, it's not appropriate for us to take you to the lab. It extends the expertise and creates partnerships, and there's also research opportunities looking at the benefits and limitations of this type of approach. And you can think about it in your own community, but you can think about the expansion beyond that. So certainly within the Minneapolis Heart Institute, we now have telehealth at Naples, Florida, given that we have a lot of snowbirds that go to the area. Gives us the opportunity to maintain that connection with the patient. You can even think about international collaborations. Last night I was thinking about this. I also thought you guys have real live cases that you share and demonstrate and learn techniques from. You could use this in routine care to help provide consultative services to someone who might be doing a new approach or a new technique. So mobile technology, certainly we've started to leverage mobile technology first to help providers. So what's the problem? We had providers out in our referring system that had outdated protocols in terms of the management of care. So for a STEMI, they didn't know what they were supposed to do in terms of were they supposed to give lytics. We have a half-dose lytic system as well. Are they supposed to get dual antiplatelet therapy? So they had old information, outdated care that we had trouble maintaining. The info was not accessible, so they might have a poster somewhere in the emergency department, but it wasn't at the point of care. They didn't know where their protocols were. And it's challenging to update. So if we have some 50, 60, 70 odd referring centers, how do we update that information to make sure our referring centers are up to date to what they need to do? So the Cardiovascular Resources App was one approach that we've used to improve the delivery of care. It's essentially PDFs in an application form so that on their phone they can pull up and see what are the protocols I'm supposed to be following in care. And it also provides real point of care touch contact so that they can call us and discuss the patient and make sure that they're approaching these things correctly. So fingertip access to current cardiovascular protocols, single-click access to consultative input. We get more than 4,000 calls annually on this approach, and it's very simple in its functionality. So we've intentionally kept it simple so that providers find it useful. If we made it overly complicated, I don't think that they'd use it as much. But then the question becomes, how do we extend this to the care of our patients? So more than 70% of Americans have smartphones, and that was updated a couple of years ago. It's probably upwards of 85% now. A lot of these are integrated with devices. I have a watch that's integrated with my phone that tracks a lot of data, but we don't use that data to support healthcare. And if you've spoken to any healthcare delivery innovation companies recently, you know that there are a ton of companies that are focusing on how do we leverage all this data to improve care. So we've got this massive data, and there are companies that are developing patches that can capture 20 biometric data points and put that on your phone. And the thought is that that will lead us to the future in the immediate short term. I think that's not likely going to happen. I think there are going to be specific use cases, but I don't think you need to worry about the data from somebody's watch being part of what you're going to be asked to do in routine care. I think we are going to find specific use cases where mobile technology and data is going to help us. The first, home-based cardiac rehab. We know that there are data in their studies that have demonstrated a mobile-based cardiac rehab program is as effective as brick and mortar. So if you live in a community that doesn't have cardiac rehab, we can provide you a mobile app that will ask you, have you done your exercise today? Have you taken your medications? And provide you the educational content that's part of cardiac rehab that improves patient outcomes. So it allows us to reach beyond brick and mortar to provide the benefit for cardiac rehab, improves patient outcomes, reduces readmissions, and now there's a reimbursement model for this as well. So CMS has changed reimbursement to allow you to bill for this type of services through a mobile device and creates an incentive to do this type of work. The other part, I spoke briefly about the importance of capturing the outcomes that are important to patient. Increasingly, we're going to be asked, did you improve the outcomes of this patient? Not in terms of did they live or die, but are they feeling better? Are they back to work? Are their symptoms reduced? How's their quality of life? And we need interfaces that allow us to capture that data, and a mobile platform does just that. It can interface with the patient and ask, how are you feeling today? What is your symptom burden? Help us understand if we achieve the outcomes that are important to the patient. Will be increasingly important for quality and reimbursement measures, and proactively we can identify opportunities to improve patient care. So if you have a patient that goes back to the boonies and they have recurrence of anginal symptoms, you won't know that until they return to their primary care doctor, who may or may not identify it and then refer them back to you to improve their care. If you're surveying that patient about their return of symptoms, you can identify that and intervene more quickly. Finally, how do we leverage our data to improve our outcomes? So I'm a runner and a marathon runner. This is Elliot Kipchoge, who is trying to break the 2-hour barrier. And he worked with Nike to capture as much data about his training program, his shoes, his recovery as possible to understand how they could kind of bend the curve in terms of breaking that 2-hour barrier, this mythical 2-hour barrier for the marathon. And by capturing all this data, looking at their training, opportunities to improve and be more efficient in the way that they ran, they did jump that curve. They made a dramatic improvement in his time, almost breaking that 2-hour barrier. They did some things that actually wouldn't qualify because he was drafting, but at any rate, had a significant impact in understanding how they could do better. In the same way, in the cath lab and in our cardiovascular care, we can't improve what we don't measure. And so we need good data to see the gaps and identify the variation. Within our own healthcare system, we capture data from somewhere in the order of 80 different streams of data. We collate that data in a way that allows us to identify gaps in variation in care and improve both the outcomes and the efficiency of our care for that high-value care that we're seeking. But measurement alone is not the answer, so the keys to success are stakeholder input. As a general non-invasive cardiologist, I can see the data and identify potential opportunities, but I have to collaborate with my interventional cardiologist to truly understand where the opportunities are, and that has to be in partnership with our operational partners, so we invest the resources necessary to get to where we're going to achieve benefits. So that's where that success is achieved, is the overlap between the data analytics, the clinical insight, and the operational insight. And you also have to have transparency in what the motivation is. Value is different depending on the eye of the beholder. So if you don't have transparency in why you're trying to improve this outcome, you'll get pushback and people will dig in their heels and say, I don't see how that's beneficial either to our practice, to our patients. So there needs to be a conversation and understanding about what is the motivation to make that change. What's possible? So as a result of using and leveraging our data in the past 3 years, these are some examples of improvements that we've had. So 1,000 ICU admissions avoided, a reduction in lab testing, a reduction in heart failure readmissions. So significant impacts, and the impact of the healthcare system is on the multiple millions of dollars. So this provides us the incentive to keep doing this work. So with that, I'll close by saying again, a state of mind. It's not necessarily about generating a completely new idea, but thinking differently about the ideas that we have and the technology that we have available to us already. Thank you very much.
Stephen, that was really nice, really forward-thinking, but also kind of bringing it home to what we have available to us right now. I think one of the things that always strikes me is the misalignment between motivations amongst the groups that you mentioned. Obviously, we want to connect with our patients. That's what we want, and we want to provide them good care. But sometimes the payer models are barriers. One way to interpret, for example, 1,100 admissions avoided to ICUs is $220,000 of billing avoided, to physicians. And how, the innovations that you're talking about, whether it be an alert that a patient wants their medication renewed in Epic, how come the technology and the payers are not kept up with our ideas about how we really want to take care of our patients efficiently?
Yeah, absolutely. And so this relates to the tension of how do you truly achieve value for care delivery when incentives aren't necessarily aligned. So I think that we've really tried to focus on those areas where there is alignment, and so there may be opportunities to both improve the outcomes while maintaining or actually optimizing our revenue. So if we're improving our outcomes for our patients, then at least we feel aligned within our health system. Certainly that's our payers that's challenging, because then we need to talk to them about where are the opportunities where maybe we do less, so we admit less often to do less procedures, but how are you going to reimburse us in a way that helps us continue? Certainly we can't do something that's going to cut our leg off. Otherwise, we can't stand financially. So a lot of the work that we do provides the financial umbrella so that we can do other aspects of work that potentially don't have that same financial compensation or motivation.
Mm-hmm. And I think one important thing is to not abrogate our roles as leaders and instead become the person who has to obtain the pre-authorization for the test or the renewal of the prescription and all these sorts of things, where it's like, this is efficient, but it's efficient by not having as many people employed. And I think we have to understand that it's not beneath me to renew a prescription. I don't care, I can do it on my phone. But maybe that's not the optimal use of my time.
Right, absolutely.
Yeah, I love that, Steve. It's an outstanding talk. And I think, yesterday there was a headline about the number of 100,000 new startups and the dramatic amount of money that have been put into this. But almost all, like more than 95%, are losing money. And I think it's because it's misplaced. And the point is, when you start with the patient, what are we trying to do? We're trying to make care better. And understanding where those gaps are, I think personally, for all of us in the room, it's our responsibility to be part of providing good care and value-based care. And so I think it's really a great talk, and it's applying what we know, which is the most important.
Steve, do you think this will give us an opportunity to have heart teams with heart conferences, even at sites where there isn't surgical backup for PCIs, and really help to make better decisions for patients?
Yeah, I think you're talking about leveraging essentially the mobile technology component or telehealth to essentially create a virtual heart team, and I think that's an outstanding idea. Certainly some centers aren't going to be large enough to have their own freestanding heart team within their center, and so I think that would be leveraging that technology in an innovative way to provide that collaborative care that would achieve the best outcomes for the patient.